know racism when I see it.
Joining us now is Dr. Gary Gibbons. He is the director of the National Heart, Lung, and Blood Institute at the National Institutes of Health. And Dr. Gibbons, thanks for being with us. And I guess the first question that I would ask is that from an African-American standpoint, and I am hearing this from my own relatives, a lot of us don't know that we have pre-existing conditions. And I found out from emails from both of my sisters that they qualified as part of 1B. So what should we be looking for as African-Americans that would put us in that category?
Well, certainly one of the elements, this is derived from the risk of developing COVID-19, and particularly the risk of developing the severe complications requiring hospitalizations, and indeed the propensity to have a fatal outcome. And we recognize, having studied this disease over the last year, that there are certain groups that are predisposed to have more complications, more severe COVID. And that includes individuals with conditions such as cardiovascular disease, high blood pressure, diabetes, obesity, chronic lung disease. And so those are particularly some of the groups that are of concern. Obviously, those who are older tend to have more severe COVID complications, so those over 65. And you're finding that that will be mirrored in those who should be really the top priorities to get vaccinated in order to prevent them from developing COVID-19 and those severe COVID complications. So that's why those are at the highest part of the tiers. And certainly individuals should consult their primary care physician or caregiver to get any clarifications about where they fit within that risk profile.
Dr. Gibbons, we hear an awful lot said about the last time, and you hear a lot of people talking about the Tuskegee syphilis experiments, but the truth of the matter is African Americans, and specifically African American men, don't go to the doctor. So a lot of the risk factors that you're describing, is it safe to say a lot of Black men specifically don't even know that they suffer from those conditions?
Well, you're raising another important point there, that we recognize that for the vaccination, having a primary care doctor, having a medical home, if you will, would be most advantageous in this context. And as you're pointing out, that access varies quite a bit. And that will be one of the areas that I think as the new administration rolls out its vaccination plan, that we'll have to be very vigilant for that group. So it'll be critically important that we do so in a way that acknowledges and recognizes that gap in our healthcare, medical care system, and compensates for it. This pandemic has revealed and amplified that it occurred on the top of longstanding health inequities, the longstanding inequities in access to quality care, in which case, as you're pointing out, some of these conditions probably were undiagnosed. And this is really another call to action to be sure that the vaccination is done in a way that couples and actually builds better resilience into our medical care system, such that those individuals at highest risk do indeed get vaccinated and also are on a pathway for better care of those conditions.
How concerned are you that as African Americans, we are consumers of the media, but not necessarily like I do? For instance, every morning it's a daily digest of about 3 or 4 hours of news and newspapers, et cetera. But I remember in the early days of the pandemic, and sometimes we need to remind ourselves that we are only in year 1, even though it seems like year 10. But in the early days of the pandemic, I remember a lot of African Americans saying, this disease does not affect us. It does, and it does in numbers unlike we have seen before. So refresh our memories now that we are at year 1. How much does this disease affect the African American community, and why?
Well, as you're pointing out, I think maybe early on, at the very inception, there was this notion that if you were traveling around the globe and had visited certain countries, whether it's China or Italy or Europe, that's where we were most concerned that were the sources of the virus. And perhaps in some of the communities of color who are not engaged in global travel thought that this may not apply to them. The truth is, as we found out, is that the virus was already here and starting to spread. And so this is not something that was limited to a foreign country or the people who travel on cruise ships. But in fact, it's in our communities and it's spread. And it's particularly spread that we learned over time by people who aren't even symptomatic, don't even know they have the virus. And so then when you examine, well, who is most likely to be exposed to the virus, it's going to be people who are at the front lines, that are bus drivers, that are healthcare workers, maybe a nursing assistant in a nursing home, the grocery store stockers. And these occupations are often occupations that are particularly prevalent in communities of color. And so the cases were particularly high, 2, 3, 4-fold higher in communities of color, and they still are. And moreover, that high caseload and exposure led to higher rates of hospitalizations. Again, 2 to 3-fold higher for Black and brown communities compared to white. And unfortunately, once hospitalized, greater death rates. And those disparities have persisted throughout the pandemic. And so it's critically important that communities of colors that are disproportionately affected by the pandemic be amongst the highest priority to get the protective, therapeutic, and vaccine treatments necessary to crush the COVID pandemic. And so this is really a call to action to really promote vaccination and immunization efforts in communities of color to protect them as a high priority.
We continue our conversation now with Dr. Gary Gibbons in the National Institutes of Health. Stay with us.
We can do better and deserve so much.